Making discharge lounges actually work is our episode topic. My guest is Ellie Crook, Chief Nurse Executive at Northwestern Medicine Palos Hospital. Ellie shares successful results seen from implementing a discharge lounge at Northwestern Palos, including reducing the average 4-hour discharge process to less than 1 hour, as well as a 49% reduction in emergency department left without being seen rates, among other successes. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Shimalewski.
Ellie, thank you so much for joining us today.
Good morning.
Can you tell us a little bit about Northwestern Palos Hospital?
Northwestern Medicine Palos is located in Palos Heights, Illinois. It was incorporated into the Northwestern Medicine System in 2021. It is a little over 400 beds, and it provides all services, medical, surgical, has an emergency department, a large community hospital in the south suburbs of Chicago.
And how long have you been in your current role?
Since September of 2021.
And so today we're here to talk about discharge lounges. What was the impetus for implementing a discharge lounge at Northwestern Palos?
Yeah, it actually came up on the fly. It was the fall of 2022, and we were really struggling with volumes. We were having trouble getting patients out of the hospital. Our emergency department was backing up. We were boarding anywhere from 30 to 45 patients a day. We came in on a Monday morning, and it happened to be December 1st, and said, there's 30 patients waiting for beds. We got to do something different today. And so we crashed it open, even though we were planning to put some strategies in place to open one anyway, but it worked doing it on the fly.
Let's get into the mechanics a little bit of how your discharge lounge operates. What are the hours of operation? How is it staffed? What's the process by which it's used?
So we've done a couple of iterations on this. Our first iteration, when we open it up, we have a great area right off of our front entrance where our surgical patients get discharged from. And so we use that area. It has 5 bays. It was originally open Monday through Friday, 9 to 5, and on Saturdays from 9 to 2. But more recently, in the last 3 months, I would say, we started just doing it during the week, Monday through Friday, 9 to 5, sometimes 9 to 6, just depending on when the last patient leaves the lounge. Our first iteration, we staffed it with our pre-procedure, post-procedure staff who lived in that area. But with our second iteration, we decided to staff it with our education coordinators. We found that having a more consistent team rather than somebody just running over and manning it and running back helped us get a better process in place. So we staff it with one education coordinator and one certified nursing assistant.
And so what is the process that is used for the discharge lounge? If I'm a patient or there's a patient that's up for discharge, how do they get to the lounge? What's the inclusion, exclusion criteria?
Yeah, so interesting. We have very few criteria. Dr. Moran, our chief medical officer, and I wanted to make it simple. And his mantra was, if the patient has a discharge order and can discharge through the front door, they can go to the discharge lounge. That's our criteria. Makes people a little bit nervous. Some people say, have you talked to risk and have you talked to this person? It's very simple. And as of today, we've put probably over 1,000 patients through the lounge, and knock on wood, not one of them has actually had to go back to their room. So they really are cleared for discharge and can go right out the front door.
And is this just a waiting area that they're waiting for their ride to pick up, or do they go there and continue to receive education and discharge instructions? Like, when does the care stop up on the floor, and what is done in the lounge itself?
Yes, so we are still working to advance that. So it has been just if you're discharged, you were getting your discharge instructions on the floor, and then you were coming to the lounge. Once we put the educators down there, we have the ability to do further education and teaching with the patient family as well. And we're looking to advance. Could we give some medications that anything that somebody needs just before they're leaving that keeps them in a bed that we actually need for the next patient?
Can you talk a little bit about your results that you've seen since implementing?
Yeah, so results have been pretty fantastic right out of the gate. In the first 3 months prior to standing up the lounge, we had a left without being seen in our emergency department around 12%, which was close to about 600 patients a month. And with the month of December and moving forward, we reduced that to under 5%. Now, some of that is not all based on the discharge lounge, right? Some of it has to do with volumes in the ED, but pretty significant decrease in the number of patients that leave without being treated in the emergency department.
Is that the key metric that you're looking at, left without being seen, or how has it impacted your O to E ratio on the inpatient side or your admission length of stay, avoidable days, things of that nature? Any results
Yeah,
there?
the other metric that we tracked is our patient engagement. And so, what it did within the net promoter score is one of the metrics that we use. Before we started, the emergency department was in the negative numbers. So, the month directly prior to standing up the lounge, they were a -9. And the month that we stood up the lounge, they were a positive 27. So we've seen a big swing in patient satisfaction within the emergency department. Little harder. There's so many other moving pieces with length of stay upstairs. I wouldn't attribute the lounge to that totally.
Okay, fair enough. Discharge lounges are often talked about as strategies to reduce length of stay, boarding, expedite the discharge process, but it seems like there are so many organizations out there that have tried this and been unsuccessful. What do you think was the key to making this a success at Northwestern Payless?
Yeah, I think the key to success is keeping your foot on the gas pedal. We were committed to making this work. And we noticed that if you take your eye off the ball, then people go back to their own habits. There's a lot of perception from the nurses on the floor that this is a lot of work because if they discharge this patient, they're going to get the next patient, right? And so they tend to hang on to the discharged patient till later in the day. They get their day kicked off, and that's the last patient they touch. And so we spent a lot of time doing road shows saying, we need you to focus on this patient first because we have to get this patient out. And so getting them to understand the importance of the discharge lounge and the importance of throughput has been a year-long journey. The other thing is we made it more of a pull than a push. And the key person in our discharge lounge at times is our certified nursing assistant, because once we know that the patient is ready for discharge, that person will go up and pull the patient out of the bed down to the lounge rather than waiting on the staff upstairs to send them to us. And then I think the third thing is recognizing that once the families arrive in the building, all bets are off, right? Because they're there, they want to help, they tend to slow the process down. And so we know that we have a very short window in the morning before families start to arrive to try to launch patients quickly to the lounge.
Yeah, that this pull concept that you're talking about is quite interesting. What I heard you say, and let me make sure I understand this. You have some type of board or availability to be aware of discharge orders that are placed. And when you see those discharge orders that are placed and they're going home, it's the discharge lounge that is pulling those patients. They're not eligible or things of that nature. They're going home. Here they
They're going home, they have a discharge order. The nurse in the lounge can review the chart to just make sure there isn't anything holding them up, and we'll grab them and pull them down.
Wow, huh. I like that. How many patients a day are you putting through this lounge?
It tends to fluctuate. The most we've done when we've been really busy and everybody's humming is 24. Some days we don't necessarily have the push behind because the ED is actually doing okay. But if we could just get everybody doing 24 every day, we'd be in a great place for patient throughput.
So does the use of the lounge tend to vary based upon your overall capacity in the organization?
It did in the beginning, and then it certainly does when we are really full. On any average day, if the ED is doing okay, we probably send anywhere from 5 to 10 patients.
Okay. And you've sustained this now for over a year. You've had multiple iterations, but it's not like this is something that has gone away. What do you think the key to keeping that foot on the gas pedal has been? You made that reference earlier. How have you been able to sustain this for over a year now?
Yeah, we put a manager over it. So one of our inpatient managers oversees it. She's continuously working with the 5 educators that staff it on a daily basis to keep them moving. We collect data. Our throughput coordinator and director actually collect the daily data. They send out how many patients are coming every day. We try to recognize the units at the end of the month that have sent the most patients to the lounge. And I think our message has just been, it's not going away.
You talked earlier about you just did it. Like you were in a pinch, so to speak, and you just implemented it. A lot of other organizations that are thinking about this, some may be having a lot of thoughts and get stuck in this analysis paralysis, so to speak, trying to make the process perfect rather than just moving forward and implementing it and working out the kinks along the way. Can you talk about one, your decision to do that, the need for change and the need to do it now, and then two, any potential risks or negative outcomes that you have? Because I'm certain that some organizations that are still a little leery about the concept maybe want to try to mitigate all of those risks up front.
Our guiding principle was we would certainly never put any patient in harm's way, right? And that's where we said if the patient has a discharge order, medically ready to discharge, and discharging through the front door, they're a perfect candidate for the discharge lounge. Within our electronic medical record, we don't officially discharge them from the system. We pend them and they actually end up landing in a bay, so to speak, within the discharge lounge so that should something happen and we needed to put them back in a bed, it's not a complete discharge out of the system and then readmission the same day. So we do still hang on to them to give people a little bit of a comfort level should the patient need anything while they're in the discharge lounge. But it's more just sometimes we just have to get out of our own way and try things. And now looking back over a year and over 1,000 patients, it's worked. Now, like I said, nobody actually has gone backwards to a bed of all the patients that we've sent to the lounge.
Amazing. Any closing thoughts as we wrap up this episode?
Stick to your guns, push it forward. We've made a video that's on all of our on-demand patient TVs with some of the nurses that actually participate in the lounge and continue to talk about it and drive it forward. Because if you take your eye off of it, there's a tendency to not want to keep it moving. And that could happen very easily if we weren't determined to keep it going.
This video, that's a great idea. So tell me more about this patient video.
We actually wanted to figure out how to sell it to our patients. And the first thing we did is 3 of our educators who work in the lounge took it on their own. They actually did their own scripting. They had a really great time with it. And they made a YouTube video. But we can't, very hard to get YouTube videos to patients. And so what we did is our marketing team came in and actually created a video. And it's on demand now on our televisions for patients to see. And so we play that when they're entering the room. And then the nurses have it right at their disposal to help explain the discharge lounge to the patients.
If any of our listeners are interested in getting a hold of that video or seeing it, would it be okay if they reach out to you?
100%. Yeah.
Excellent. Making discharge lounges actually work has been our episode topic. My guest was Ellie Kruk. Ellie, I learned a lot about discharge lounges. I knew a little bit to begin with, but your open approach really seems to have leveraged success on patient outcomes. Thank you so much for joining me.
Thanks, Nick.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.